conducted under the umbrella of the Saudi Society of Blood and Marrow Transplant. I would like also to thank Novartis for sponsoring this webinar tonight. The focus of the webinar tonight is about chronic myeloid leukemia, reshaping CML. We have two distinguished speakers tonight, Professor Andreas Hokas and Dr. Ihab Al-Hamidi. The schedule is going to be two small talks. The first talk is by Dr. Andreas, who is Director of the Comprehensive Cancer Center, Central Germany, Jena Leipzig, Head of the Department of Hematology and Medical Oncology, Coordinator of the University Tumor Center, UTC Jena University Hospital, Jena, Germany. His main interest is MRD, mineral residual disease, and CML and resistance in CML. His talk is going to be updates in chronic myeloid leukemia, and that will be followed by Dr. Ihab Al-Hamidi's talk. Dr. Ihab is a consultant, adult hematology and blood and marrow transplant at Princess Noura Oncology Center, Cancer Center, King Abdulaziz Medical City, Jeddah. Without any further ado, I would like to ask Dr. Andreas to share his screen, please.
Yeah, hello everybody, and good evening. Thank you very much for the kind invitation to your meeting and to your country. I was invited to update you on the news on CML in this year. What did we learn? What are the news? Which new drugs do we have available? And also, which new goals do we have in the CML treatment? These are my disclosures. I receive research support from all the companies who are involved in CML management. When we compare the mortality rates in hematology, and here are two examples, Hodgkin's lymphoma and CML worldwide, then we see a rapid improvement in CML in the at the edge of the century, of the last century, with the introduction of imatinib, of course, with the tyrosine kinase inhibitors. In Hodgkin's lymphoma, we saw a very slow but very significant improvement of survival, of course, based on the better tolerability, but also on the better activity of the drugs used. But in Hodgkin's lymphoma, tolerability played a major role over the development of new treatment schemes. And I think that's important for CML as well. But we had been very happy with the introduction of imatinib. Now we are more in the era of improvement of tolerability of what we do, because it's for a lot of patients a lifelong therapy. And when we ask patients about their perception of how CML treatment affects their life, we get answers from more than half of the patients which are negative. They are physically fatigued, they are emotionally fatigued, they have limitation of personal social life, they cannot exercise as much as before, and they're constantly stressed and worried about treatment, if the treatment works. That's important to consider for our management, for our strategies. And when we look at patients and doctors, here in orange, patients, in blue, the doctor's answers, first line, second line, and third line, left, middle, and right columns, then you see that in the beginning, the patients have the goal to slow or stop disease progression. They learn that they have CML, and of course, they want to know whether this can be stopped, the disease can be stopped from progression, and so on. We as doctors, we know that we can help these patients with tyrosine kinase inhibitors. Therefore, we already in the first line therapy select according to the improvement of quality of life. That means we consider the side effects of the tyrosine kinase inhibitors already in the first line. But when you look at second and third line, patients have learned that their CML can be managed with the tyrosine kinase inhibitors, and they have the major goal of improvement of quality of life in all these situations. When I started with hematology in the 80s, we had 3 phases of CML, and for all patients who did not receive allogeneic stem cell transplantation, we had an ultimate progression of CML chronic phase to accelerated phase or directly to blast crisis. In the new WHO classification, we skipped the accelerated phase because we don't see it anymore in the course of the disease, because we react immediately when we see an increase of the PCR levels. That means we don't see loss of hematologic response, and we don't see the slow progression of CML anymore. And at diagnosis, the use of the term accelerated phase used to be very problematic because it was a very heterogeneous mix of different parameters. We call it now high-risk disease according to cytogenetic and molecular and clinical markers, and we don't need accelerated phase anymore. You see this here on this graph. Patients with accelerated phase, with blasts between 20 and 29% have an unfavorable prognosis, very similar with blast crisis. Therefore, we start the definition of blast crisis now with 20% blasts. I mentioned these high-risk features, higher blast count, high ELTS score, higher basophils, and most importantly, the additional chromosomal aberrations in Ph-positive cells, which are of high risk, are now summarized as high-risk features in chronic phase CML. Cytogenetics is still important. I ask my colleagues here in Germany to do cytogenetic analyses at the initial diagnosis, because patients with these high-risk aberrations, derivative 3, trisomy 8, second Philadelphia, have a negative prognosis, unfavorable prognosis, and some of them, at least the patients with -7, with derivative 3, with ISO 17, need an immediate transplantation, or not immediate, but a transplantation in the first year after diagnosis. We have also very similar to myelofibrosis and MDS, chromosomal molecular aberrations. A6L1 is the most important molecular aberration at diagnosis. We know that these aberrations are associated with slower molecular response, but we don't see an association with outcome. Therefore, that's work in progress. We need more data to put these molecular aberrations in context with the cytogenetic aberrations and with the prognosis of these patients. The ELN recommendations for CML 2020 summarized 4 first-line drugs, 1 additional drug for second line, which is ponatinib after dasatinib or nilotinib, and no real alternative options. Now, of course, we have asciminib registered for third-line therapy and later, and therefore we should consider this as a salvage drug, as a third-line drug to improve outcome and also tolerability of the therapy. We still have for salvage treatment allogeneic stem cell transplantation, and our main concerns and considerations are still the side effects of these drugs. We need to improve the tolerability for a year-long or lifelong therapy for our patients. When we look at the biochemistry, these are the dendrograms for all the inhibitors. We see a multi-kinase inhibition for dasatinib, ponatinib, and bosutinib, a more specific inhibition for nilotinib and imatinib, but a very specific ABL and BCR-ABL inhibition for asciminib, which is a very selective BCR-ABL inhibitor. And this should be considered in the development of the drug, but also in the use of the drug in case of intolerance of previous drugs. Therefore, in summary, we select the initial TKI according to goals of therapy. Do the patient want to achieve treatment-free remission? In this case, second-generation drugs should be preferred. The clinical and biological risks, comorbidities, risk of adverse events, and availability of the drug in the specific country. I do this very specifically and individually with all of my patients, and most patients get second-generation drugs first line because there is an increasing cohort of patients who want to achieve treatment-free remission. And we have these milestones defined, the failure milestones on the right, 3 and 6 months, more than 10% BCR-ABL, 12 months, more than 1%. And at any later time point, for patients who want to achieve treatment-free remission, of course, deep molecular response is the way to go to be able to discontinue the drug. That's different in the third-line situation. In the third-line situation, we defined the 1% level as a treatment goal because we acknowledge the fact that a cohort of patients does not achieve a major molecular response, but we have data, combined data from worldwide studies that the patients are in a safe situation when they achieved 1% in the third line situation. It means no need for transplantation when we have between MMR and 1% BCR-ABL. The problem is in late line therapy that many patients get cytopenias. And these cytopenias are based on the fact that they have a lack of normal hematopoiesis in the background. That means patients with recurrent neutropenias after different lines of therapy should be considered for allogeneic stem cell transplantation. But because even with a new drug, we may not achieve it in normal blood counts and also an MMR or even 1% BCR-ABL. This is very important because we see now more and more patients after 3 or 4 lines of therapy who always got neutropenia. These are the patients with a high risk at baseline, and specifically patients with a big spleen at baseline. And for these patients, we need allogeneic stem cell transplantation. We currently transplant in Europe more patients in advanced disease compared to chronic phase. This is, of course, the wrong decision because we need to transplant earlier because the outcome of patients transplanted in chronic phase is more favorable than the transplantation in advanced disease. But which patients should be transplanted? Patients with recurrent cytopenias, patients with nasty cytogenetic aberrations, definitely, but also patients with multiple BCR-ABL mutations over time in late-line therapy. Now, asciminib is a myristoyl pocket inhibitor. The myristoyl pocket is depicted here on the left figure. In addition to the ATP binding site, we have two different sites for the inhibition. That means we could combine the drugs, but we could use them also in monotherapy. The juxtaposition of BCR to ABL here inhibits the option for the self-inhibition, for the auto-inhibition of the ABL molecule, because the myristoyl tail is not available anymore. And this is substituted by the use of asciminib on the right side as a small molecule binding to this myristoyl pocket. We had a very long phase 1 study, 12 years time frame, with different cohorts, with combination cohorts, with monotherapy cohorts, with ALL, with CML, with different phases of the disease. In chronic phase, the overall cytogenetic response rates was about 54% for patients without 315 mutations and 41% for patients with 315 mutations. This was promising, and therefore the registration study was done later, the ASSEMBLE trial, but in between combination studies, asciminib with imatinib, asciminib with nilotinib, and with dasatinib. The response rates are not much better than with monotherapy, but the tolerability was worsened. That means the combinations are not better tolerated than each of these ATP binding competitors alone. Therefore, I think the way which ASSEMBLE did with the monotherapy was the right way in the third-line situation. And this is a summary of the results. The MMR at week 24 was the major endpoint, the primary endpoint, asciminib versus bosutinib in standard dose. And you see that the primary endpoint was met with a difference at 12.2% of patients who achieved MMR. At later time points, this difference has even improved. And after week 96, we have now 37 versus 15% achievement of MMR. I told you in the beginning that I consider the 1% level the way to go, the aim of the therapy in third line. And when we consider this as a success of asciminib, we have 45% of patients who were successfully treated with asciminib in the late line therapy. On the other hand, it means 55% did not respond so well, but this is not surprising because we know that in late line therapy, there are variant clones, different clones who are BCR-ABL independent, who grow BCR-ABL independent and cannot be treated with a BCR-ABL specific drug. However, tolerability there was a major improvement of tolerability when we compare bosutinib with asciminib. The gastrointestinal side effects of bosutinib were not observed with asciminib. But you see that the cytopenias on the left happened to occur as well. But this is biology of the disease, as mentioned, and not a side effect of asciminib. These cytopenias are very transient. They happen in the first 6 months, but not at a later time point, very rarely at later time points in this treatment. And in this study, quality of life questionnaires were also considered. And in blue now, asciminib demonstrates in all these parameters an improvement of the quality of life compared to bosutinib, which showed in some parameters an improvement, in others not. Therefore, our goal to improve tolerability was achieved with the third-line therapy with asciminib. Sub-analysis demonstrated that the activity is better for patients with the lack of with intolerance versus a lack of response with asciminib. The reason for discontinuation is now here shown on the left side, asciminib versus bosutinib. And for the intolerant patients on the right, we see an improvement with bosutinib as well. Not surprising because these patients don't have major resistance profiles. Alternative drugs for third line, one is, of course, ponatinib. The major problem of ponatinib is still the cardiovascular side effect profile. This can be improved with the dose reduction after response. Here, the OPTIC trial demonstrates that we need to start with 45 milligrams, but when we reduce after response to 15 milligrams, the cardiovascular side effects show an improvement, and the improvement of efficacy is larger than the improvement of gain of side effects. This is my summary, the rough guide to third-line and later therapies. In case of intolerance to 2 previous TKIs, my favorite is asciminib, because we can achieve a major improvement of tolerability. In case of resistance with BCR-ABL mutations, we may see some patients who do not respond to asciminib, and then ponatinib may be an option, but also rotation of second-generation TKIs. In case of 315 mutation, asciminib is also working, but requires a higher dose, 400 milligram per day. This is registered in the United States only, and not in Europe and other parts of the world. Here, ponatinib and also allogeneic stem cell transplantation are still options in parallel to the use of high-dose asciminib. Resistance without BCR-ABL mutations, here BCR-ABL independent pathways are activated, and we may require alternative drugs like a multi-kinase inhibitors. High-risk additional cytogenetic aberrations, here allo stem cell transplantation is the way to go, also in cases with recurrent cytopenias. Other drugs in development are olverembatinib, it's also 315 active licensed in China. Vodobatinib, development worldwide, has a limited off-target activity, may be better tolerated, therefore, and the Enleven drug, which is also 315 active. Here are studies ongoing. TFR, 50% of patients relapse in all the different designs of studies with all the different drugs. It's therefore a major aim of the current research to improve this rate of stability, but also to increase the cohort which is eligible for TFR. We did this in the TIGER trial in Germany with the addition of pegylated interferon to a nilotinib, PEG maintenance, and then discontinuation. We achieved a favorable survival rate with an 8-year probability of 85% now, which is a major improvement compared to the IRIS trial. We achieved with a combination with interferon a better deep molecular response. This was transient. At later times, after 4 years, these curves overlap. And this is most important, we achieved a trend to an improvement of molecular relapse-free survival after discontinuation with the addition of interferon, but this is not significant, this difference. This can be achieved with asciminib as well. They asked for more study. Here, asciminib was added to imatinib in patients who did not achieve a deep molecular response. And you see the numbers. There was an improvement of the achievement of deep molecular response. When imatinib was continued, a 0 response rate was achieved. When there was a switch to nilotinib, some patients responded. We did a first-line study with a combination of nilotinib, dasatinib, and imatinib with asciminib, with the aim for TFR. The deep molecular response after 1 year is 38% overall, but we observed a lot of side effects because that's quite logic. The combination cannot be better in terms of side effects than the ATP competitor alone. And this wasn't very important, it's still an ongoing study, but it's very important because it demonstrates that the monotherapy with asciminib may be the way to go in the first-line situation. Here is the Ask for Start study, which is currently recruiting 80 milligrams asciminib versus 600 milligrams nilotinib, with a very interesting endpoint the endpoint is time to discontinuation of the drugs because we want to see that the tolerability of the drugs is better in first line. The mutation profile is still a research subject. Oliver Hanschel showed at the EHA meeting several mutations which prompt asciminib resistance. This should be considered, and this can be considered in some patients with problematic mutations with a combination of ponatinib and asciminib. That's a very interesting combination, needs to be developed for problematic cases, maybe a bridging strategy to transplant, and it's very interesting. These are in vitro data, but this should be done in vivo as well. In summary, we have, after the failure of first-line therapy, we have the option to go to alternative second-generation drugs or ponatinib. In case of failure of second-line, we have now asciminib available, and at later stages, I think we need to consider allogeneic stem cell transplantation to avoid an acceleration to blast crisis, and then transplant is a major problem. With that, I would like all colleagues worldwide to contribute to the data. Here in this case, I show you the German CML study group. Thank you again for your invitation, and we will have a discussion at the end of the meeting. Thank you.
Thank you, Dr. Andreas, for this elegant presentation and the updates. So we have the second talk, and then we'll have the questions at the end. For the audience, please post your questions under the Q&A section. So the next talk is by Dr. Ihab Al-Hamidi. It's going to be about CML sequencing management and the importance of early switch. Dr. Ihab, you are on mute.
Thank you very much, Dr. Ayman. Thank you for the SSBMT for the kind invitation. And I was given the task of talking about CML sequencing management and importance of early switch. In 2001, Gleevec was in the front page of the Times magazine saying this is a new revolution in the treatment of cancer. And since that time, we had more than 20 years of experience in treating CML. And what has that culminated into is an improvement in life expectancy of patients. And this is the Swedish group. Sweden, the Scandinavian countries generally, they have a very good registry data, real world data on patients and general population. And this publication was in 2016 of a total of more than 2,000 patients between 1973 and 2013. And what they have shown in their data, as you can see here, is that for patients who are age 55, 65, 75, and 85, you can see that the survival of those who were diagnosed in 1970s compared to life expectancy, which is the blue dotted line, was lower. So as time passed by, the life expectancy has almost reached the normal life expectancy of the normal population in all age groups. And you can see here the number of years lost after a diagnosis of CML. It's approaching zero. So zero number of years lost for CML patients who are diagnosed with CML as we approach 2010. If you don't like real world data, trial data, this is one of the trials that was published, a 10-year survival on patients with CML study 14 from the German group, and it was comparing different modalities of treatment, imatinib 400, imatinib with interferon, with RSC and interferon. What is this? It is not important what these arms are, but what is important, I'm trying to show you, is that the life expectancy of these patients was almost 92% compared to the general population in a study population. So the observed was 82%. And when you when you adjust the survival for the age match group, then it becomes 92%. So very close to the general population. And you can see that the CML death from CML was only 6% of that population. And what Professor Hokus has alluded to is that this 1% difference. So patients who are achieve less than 1% level of BCR-ABL based on the IS international standard ratio, they do much better than those who achieve who do not achieve that marker of more, and they don't go below 1%. So this is an important thing in switching, is when your patients are not achieving that landmark, one has to think about switching. So switching in this trial was allowed, and more than 400 patients were switched, which was 26% or 26.5% of the patients were switched. Mostly they were switched to dasatinib and nilotinib. Some were very few on bosutinib, ponatinib, and 57 were switched to more than one TKI. The switching was mainly in the poor risk patients, and the median time to switching was 34 months. So it's a long time to switch, but at that time of the trial, people were not aware of such data, and this has led to the ELN guidelines of 2020 telling us what is considered to be failure, and helping us to switch earlier. So patients with 20% of patients who were analyzed with their BCR-ABL kinase domain had resistant mutations. The commonest one was T315I. There are other mutations as well. And 66% were switched to second generation TKIs. More high-risk patients, 31% of the patients who were switched were high-risk patients. The low-risk patient, only 16%, and the intermediate risk patient, 18% were switched due to mutations. The blast crisis in this trial was about 5.8%. And this is the most feared complication of chronic myeloid leukemia, is you want to avoid as much as possible getting your patients with blast crisis, which mainly occurs in the first 2 years after beginning of therapy. After that, it becomes much less a complication. As soon as a patient develops blast crisis, their overall survival is less than 1 year. In this trial, it was 7.9 months. So in summary of the first part of my talk, CML patients, if managed well, will have a near normal life expectancy. And one of the risks for normal life expectancy is intolerance or resistance towards first generation TKI imatinib. At 6 months, those who do not achieve BCR-ABL of less than 1%, especially in high risk group, one has to think really carefully about switching them, especially in the younger age group. And by that, I mean those who are below the age of 65, maybe 70. One has to think carefully. And also we have to do our mutation analysis in the BCR-ABL kinase domain, because it occurs in 20% of patients. It will drive us to switch earlier if we do that and we find the mutation. So the ALN guidelines, which Dr. Hokus, Professor Hokus has alluded to, has suggested that we should do our risk stratification for all our patients, because that will tell us who is high risk and who is not. I like to use the ELTS score, but all the other scores are acceptable. And you can see here that the SOCAL score in the high risk 10 years, 75% in the ELTS, 68% overall survival. So the ELTS tends to show us those high risk patients who were less likely to survive long time. And the leukemia relapse is 12% in the high risk group. So leukemia related death is 12% in the high risk group at 6 years. So again, it shows us a very high risk group of patients. These are the points of the ELN guidelines at which we should consider patient has failed if they at 3 months they had more than 10%. And if you confirm that they are more than 10% in another PCR-able, so you shouldn't depend on just one PCR-able. At 6 months, again, patients who have got more than 10% or more than 1%, again, it's a time to possibly think about switching the patient. What are the important conditions to achieve our goal of sequencing management is a reliable laboratory. We have to have a reliable laboratory because we are depending on switching, TFR, managing our patients on levels of BCR-able. The laboratory or molecular laboratories will be able to detect for you the common mutations, the typical ones for CML, the E13A2 and the E14A2 BCR-able transcripts. These two. There is a group of patients, 2 to 4%, who will have harbor an atypical BCR-able transcript mutations, like the abnormal or unusual BCR-able breakpoint in the able gene, A3 and A3. Here the breakpoint in the BCR is the typical one, but the able gene is not, is atypical. There is another atypical breakpoints in the BCR breakpoints, which are these ones. And these ones will not be detected by PCR, our routine PCR. And this group of patients we have to be very careful with. BCR-able, our lab ought to use the IS score, which is based on the IRIS trial, which is the first trial which used imatinib. They consider the IRIS 100% as the baseline, and the IRIS 1.1% is the IRIS MMR level. And we all try and emulate that because this 0.1% resembles the point at which we are sure that our patient is actually in a good, what we call safe haven. In an area, if the patient achieves that goal, then they are in a place where they are very unlikely, almost unheard of, to develop blast crisis, which is the thing that would kill our CML patients. Why we shouldn't depend on labs that doesn't have the IS score is because you can see in this example, the cutoff, the IS is the red line, and this patient, red one, has not achieved the cutoff point. So compare this to the green one. Patients had a very high BCR-able at the beginning. They achieved 3 log reduction, but they're still above the cutoff. If you are using a lab that doesn't have the IS score, you will think that this patient has done very well. They have achieved 3 log reduction, but they're still above the cutoff point, as you can see here. This patient has achieved the cutoff, and they usually will do well, such patients. And for this reason, it was established by the WHO, a genetic reference panel to look at what we have and to standardize our methods. And this is a diagram that shows the equivalence of the molecular genetics to our cytogenetics and the number of cells that are expected. The ELN guidelines give us a control group. We can use the ABLE or the GUSP as a control for our PCR. And these are the levels at which we should get. The higher the MR level, the MR 4.5, we should get an ABLE control level of 32 to be able to sufficiently say and confidently say that we have reached an MR 4.5, and an MR 5 again requires a very high level of transcription production by our PCR to be able to be sensitive to detect that level of reduction. So in summary, using a lab with a validated PCR and IS standard is crucial in sequencing therapy, also important in making the right choice for patients who undergo treatment-free remissions. So pitfalls for early switching is adherence or compliance. And this article here was looking at factors that CML patients, why they would not adhere to our therapy. This is the most common cause for lack of control in our patients, and we have to look at that very carefully and try and avoid. This publication was more than 2,500 patients in 63 countries, and they based their looking at adherence using this MMAS8 score, which is used for many medications, asthma medications, hypertension medications, but in this trial it was used for imatinib or TKI medications. And they would categorize those who score 6 points or less than 6 points as low adherent patients, medium is 6.6 to 7.7, and high is 8 points adherence. Overall, 2,546 questionnaires were completed by the CML patients in 63 countries, and some were mostly returned as online and some were returned as paper. And what they found is that 32% of the participants were highly adherent, 46 were medium adherence, and 20 were low adherence. And one of the interesting findings is that they found that men statistically are more adherent than women in this study. The main factor that can cause influence, at least partially, is the quality of doctor-patient relationship and the management of side effects. These are very two crucial points in which you can improve adherence of your patients. Doctors who are well informed, they're informing their patients instead of only instructing them, are found to be more useful to the patients, and they produce more compliance in their patients. So informing patients rather than instructing them about their disease is emphasized. This is another study done by Belgium and the Netherlands. And they looked at, it's a meta-analysis of many trials of compliance adherence to medications using different methods like blood sampling, the MEMS, which is the medication event monitoring system, was used by the Hammersmith in the UK, in which the bottle sends signals how often it was open and when it was open to the center, and they will find out whether the patients were taking their medications regularly or not. So they grouped all the data from many compliance studies, and they found a difference in adherence ranging between 20 to 40% of patients were non-adherent to their medication. So adherence is a major issue in CML. It's a chronic disease. There are many reasons why patients don't adhere to their medications, and one has to spend some time with the patients to try and make them adhere to their medications. Why is it important? It's important because those who don't adhere to their medications, you can see that they get suboptimal responses, as you can see at the top of this slide. And the bottom of the slide shows you event-free survival is statistically significantly worse in patients who do not adhere to their medication. So it is a very important point to emphasize. This is a physician communication and patient adherence meta-analysis, and many studies, more than 130 studies analyzed in this study, and 104 of these studies were positive from the respondents, and they have shown that non-adherence is more than 1.4 times greater among individuals whose physicians is a poor communicator. And it's 19% risk of non-adherence if the physician is not a good communicator. 2.1 times better if the physician is a good communicator. So communication is important. Intolerance is again a risk factor for poor outcomes in patients, and you can see the different side effects of the different medications. One has to be aware of them and try and deal with them appropriately with the patients so that you can get better outcomes with the patients. Failure secondary to resistant mechanisms. We talked about genetic mutations, BCR-ABL mutations that confer resistance to some of the TKIs that we use. This is a more up-to-date list of mutations that have been documented in the BCR-ABL gene. In 2019, this paper was published by Susan Bramford from Australia. They were laying the foundation of genomically based risk assessment in chronic myeloid leukemia. In Hematologica, the Hammersmith group published this in 2019. The presence of somatic mutations in imatinib might be a reason why patients might not be responding. And they have shown in this study those with somatic mutations, the red line, the cumulative incidence of MR3 is less. The progression event-free survival, probability of event-free survival, the red group with somatic variants is much less, statistically less. And the progression-free survival is statistically less in those with somatic mutations. And again, the CML-related survival, again, is statistically worse in patients with somatic mutations. This publication with the German group spoke about or published the SXL gene. But with the SXL gene, these are all the other myeloid mutations that you might find in newly diagnosed CML patients. We don't know now how they affect our response. It's still under study. But it seems that SXL tends to confer in a proportion of patients, less patients achieve MMR at 12 months, 18 months, and 24 months. Again, another group, the MD Anderson, produced similar data to the Germans, with, again, SXL being a poor risk for prognostic factor for the CML patients. You can see SXL patients do worse in event-free survival and overall survival in the MD Anderson. So it's data that's recurring in multiple groups. So physician role, finally. This is a very interesting study. I advise you to look at it. People who know me know that I like quality. And this study was from the Netherlands, very interesting study. They looked at what are physicians doing. Physicians are very good in talking, like myself, and doing guidelines, but are we adhering as physicians to what we write as guidelines? So the Netherlands, they've done this study in more than 300 centers, published this year, and they wanted to look at 7 indicators, whether the physicians are following. These indicators were taken from the ALN guidelines 2020. So indicator 1, diagnosis of patients with complete diagnostic molecular and cytogenetic workup at diagnosis. What percentage of physicians followed this? Indicator 2, what percentage of patients started their TKI within 28 days of diagnosis? And indicators 3 to 7 were percentage of patients who had cytogenetic and BCRL monitoring at defined milestones by the ALN guidelines. If there is a milestone failure, did the physician do mutation analysis within 6 weeks? If there is a mutation, did the physician switch to new BCR sampling within to switch to a new TKI? New BCR sampling within 2 months of failure, did they do that? And what they found is surprising. Well, it's not that surprising, but it's something that we have to reflect on. And you can see that if those who followed the indication number 1 at diagnosis were 83% of the physicians, indicator number 2, 78%. And as you go with indicators 3, 4, 5, 6, 7, the percentages fall to 27, 25, 21. So very low compliance with our guidelines that we produced ourselves. In our guidelines. So this study shows that adherence to guidelines in the real world clinical practice is lacking and not as strictly timed as in clinical studies, and surprisingly, staggeringly low compliance. Those who did the 7 was only 5.8% of the physicians. Some now who is hearing me speak might think maybe we should stop producing guidelines. Why are we producing guidelines that no one follows or the majority of physicians follow? But you can see here, again, they've shown clearly that those patients who had zero quality indicators performed did much worse in survival compared to those patients who had 1 to 4 and more than 4 quality indicators produced. So following guidelines, following improves patient survival. And again, they've shown here that disease progression is much higher in patients who had 0 indicators followed compared to those who had 1 indicator or more followed. So again, following guidelines help our patients. So the person who reads too much and uses his brain too little will fall into the lazy habits of thinking. Let us not just think and ponder. More importantly, we should act on the knowledge we have. So in conclusion, sequencing therapy appropriately leads to improved patient outcome. There is a need to train physicians to apply guidelines judiciously, and physicians ought to be able to inform patients and communicate effectively so that they improve the patient adherence and compliance to their medications. And better compliance leads to better outcomes. Early detection of adverse events and dealing with them is very important and crucial. And early detections of resistance to therapy is again a crucial point, and use of a reliable lab is again very important. And thank you for listening.
Well, thank you very much, Dr. Ihab, for this enlightening presentation. We always talk about compliance of patients to medications, but we never talk about compliance of physicians. Thank you for bringing this up. It seems that we don't do as well, and probably patients don't do as bad as we do. I guess there are no questions, but have a question to Dr. Andreas. You're with us, Dr. Andreas?
Yeah, of course, but
Yes.
they stopped my video. They now I see you again.
Here you go.
Hello.
All right.
Yeah.
Okay. Yeah. I mean, despite that, a simple trial was conducted comparing asciminib to bosutinib in the after 2 lines of therapy. Taking into account the results of this trial and probably the results of the OPTIC trial, where de-escalation of ponatinib was introduced to ameliorate the side effects. I mean, in the 3rd line setting, which of these 2 drugs would you prefer and why, if we take outside T315I mutation?
Yeah. Difficult question, because there is still lack of data on the impact of BCR-ABL independent mutations. That means we need more knowledge on A6L1 and all the other mutations, whether they inhibit the specific activity of asciminib on the BCR-ABL. Yeah, and I think that's really important when we compare a multi-kinase inhibitor with a specific drug. But in addition to these 2 options, please don't forget the rotation of the 2nd generation drugs. That means when we have imatinib 1st line, nilotinib 2nd line, why not dasatinib in 3rd line? I think that's an option as well, yeah, or bosutinib. We have a multitude of different options. And I think both talks today demonstrated that we need a very, very comprehensive analysis of the biological situation of the specific patient. Mutations outside of 315 are also very important, and BCR-ABL independent cytogenetic or molecular aberrations. And of course, the situation of the patient. That means comorbidities and the side effects in the past. That means when a patient had a lot of side effects, has cardiovascular problems, and then of course asciminib might be the better option to try immediately. For a patient without these problems, of course, ponatinib might be used, but not forever. That means ponatinib has its restrictions as well. We cannot use ponatinib for 10 years, then we will produce cardiovascular problems. That means it's very individual, and I'm happy to have both drugs available.
How about in T315I mutation patients?
Yeah, unfortunately, the registration is only in the US for the high dose. But again, unfortunately, we don't know whether a lower dose might be work in 315 as well, when we have 315 only. In the phase 1, we had a mix of different situations. We had some patients with several mutations. We had patients with BCR-ABL independent situations in addition to 315. And overall, the 400 milligram dose of asciminib was considered as a salvage therapy for these patients. But it may be the case that the 200 or 120 may work as well. That's still open and needs to be discussed. But for the time being, we have no registration for higher dose, and therefore I think we need to use ponatinib or one of these other drugs which I showed in clinical trials.
Thank you. Dr. Ihab, at 6 months, switching to another TKI, although the target is less than 1%, but it seems a general recommendation would be not to switch if less than 10% at 6 months. Do you do that, or what do you do for patients between 1 and 10% at 6 months?
I take an individualized approach. I think for elderly patients, 70, 75-year-olds, I think switching, if it was 1% or 1.5 or 2 at 6 months, is not a rational thing to do. However, in young patients, especially 20-year-old, 25-year-old, 30-year-old, if they have more than 1% at 6 months, and I had several PCR-able tests done, I would consider doing the BCR-ABL mutation analysis. Maybe one, I haven't been doing this, but maybe one should think of somatic mutations as well, to try and understand the biology of their disease. I have to say the most important thing that I haven't mentioned, which I should mention first, is adherence. So how adherent was my patient at 6 months to their medication during that period of time before I make the decision to switch? If they were not adherent to their medication, I spend an awful lot of time with them to try and gain their trust. I think I wouldn't, if there is an issue of compliance, I would not definitely switch at that point. But if I find that there is enough evidence that the biology of the disease is not the straightforward disease in the younger patient, I would switch.
But I think in addition to what you said, it's important which drug is the first-line drug. If it's imatinib, I absolutely agree with you. Then we should switch as soon as possible. If you started with a second generation and you end up with 3-4% at 6 months, I'm very reluctant to switch here. I wait a little longer.
All right, just a continuation for switching. We know the milestones, and the minimum you need to achieve post 6 months is MMR, which is less than 0.1%. But in few patients, only the maximum you can get with the first-line therapy, or even sometimes switching them to a second-line therapy, is around 1%. And do you really recommend to switch those patients to a second line or a third line if they have achieved only less than 1%, but did not achieve MMR or 3-log reduction, which is less than 0.1%.
At which time point?
I mean, after a year of being on TKI.
Yeah. Our goal or our failure criteria are 1% at 12 months or later. And if this was not achieved, of course, then I would switch in first or second line, not in third line.
Not to third line, but you will switch to a second line.
No, please don't confuse second line and second generation. You mean second generation or line? I was talking about first line and second line treatment. If these lines of therapy do not achieve 1% with any drug after 12 months, then I switch. If we are in the
they did not achieve less than 1%.
Yes. If we are in the third line situation, that means the patient already had 2 drugs in the past and has a third drug now, then I'm happy according to our recommendations, which is based on the summary of the data, then I'm happy with the 1% level. Then the likelihood to achieve TFR is very low in these patients, and therefore we are a little bit more soft and reluctant for another switch, because our options are limited then. These are mainly the patients which I mentioned with reduced capacity of the normal hematopoiesis. And this cannot be changed by another switch.
So you're happy with the less than 1%. I guess that 1% magic number is probably taken from the correspondence of CCYR, I guess.
That's the case. You're right.
Yeah.
From earlier data, from earlier trials. This MMR was introduced with IRIS for imatinib first line, but we cannot transfer MMR to all lines of therapy. That was the first line situation, but we have analyzed patients who were in the IRIS trial between 1% and 0.1%, and actually the additional morbidity and mortality in these patients is low. Yeah.
Dr. Ihab, will you switch, like even if a patient has been on a line of therapy, let's say first line, even 1.5 years or that, or even longer, but did not achieve MMR, but was less than 1%, would you switch anyone like this?
So what you are saying is that they are, say, for example, on imatinib, and they are 0.5, 1.5 years after starting imatinib?
For example, yeah.
Again, one has to look into why they are there. Very important, how is their adherence, compliance? What's their age group? Older age group, I would not worry at all. Younger age group, I would like to know the biology of their disease. Mostly, probably, I would be happy to continue in the majority of patients. However, some patients where you can see that there is a change in the biology, or they have high risk features, this is the group where we ought to switch. So I think we have to be careful about applying the data. Not all patients, not one size fits all. One has to stratify the risks of the patients, their adherence, and their biology.
Absolutely agree. I absolutely agree. We have only few patients who get imatinib first line currently. Therefore, we have this situation not very often. But I like imatinib. It's a good drug. But when it does not work optimally, with tolerability or MMR after 1.5 years, then I would switch.
All right, with this, we conclude our webinar for tonight. Thank you very much for the speakers, and thank you for the audience behind the screens. And again, I would like to thank Novartis for sponsoring this webinar tonight, and have a good rest of the night. Goodbye.
Thank you. Thank you very much.
Thank you. Thank you.